Hi everybody. Strange not to be seeing you on Zoom, but I'm hoping you're really going to enjoy in person what you're doing today. The topic today is around explanation, planning and shared decision making. And so this intro video should give you a little bit of an overview. You need to watch this with access to the pause button because there are some other activities that you will need to be doing as we go along. And you will also need a handout which has been sent out to you with the link to this video, because you will need to click on some links or look at some additional parts within that handout as we go along. Let me know how it goes. I'd really appreciate some feedback. I haven't done a formal feedback questionnaire today, but I really would appreciate some feedback. I would like each group to email the office at the end confirming who was in the group and any learning points you've had, but I would really appreciate a little bit of informal feedback about how this has gone. I know we've not really met up in person for ages, so I'm hoping this in sort of groups of 5 and 6 is going to be really enjoyable and useful from a sociable perspective as well. So absolutely, I don't expect you to be working flat out all afternoon. Please do have tea and biscuits and admire people's gardens if you're at somebody's house and that sort of thing. So let us begin. So what we're talking about, as I said, is explanations and shared management. And this is particularly with a focus to the RCA, but also I hope improving your consulting as well, so that actually I would hope through this it's going to enhance your consulting and as well enhance your chances of passing the RCA, which I think you'll remember is marked in 3 domains: data gathering and interpretation, clinical management and interpersonal skills. And explanations, shared management comes up in the interpersonal skills as well as within the management. So it's not just good enough to know how to manage something, it's actually structuring that management plan in a really effective way that is also really important. So what we're going to do, have this little intro that we're doing. Then there are going to be some group exercises, there's going to be some agenda setting, we're going to go over a bit of theory, plenty of small group work and discussion, and I hope some coffee and biscuits for you all as you go along. So there's a little bit about consulting models, and you probably all have your own favourite models that you might be using. I think it's probably worth, from the perspective of shared decision making, talking very briefly about the OARS model. And the OARS model is designed really to provide a framework or checklist of skills when we communicate, which helps us to be a bit more intentional in our conversations and then perhaps more effective and more efficient. So the O is about open-ended questions. So we are, I suppose, thinking, if any of you are into motivational interviewing, this is into that sort of territory, isn't it? So thinking about the what, why, when, who questions, not the have you had, have you done, actually that whole what's going on, who's brought you here, how have you managed before, what are you thinking about, who's helping you with this, and then affirming. So these are the empathy statements. So those of you who've looked at the newer Roger Neighbour stuff are already really familiar with this, with the empathy statements for each time, those big cues, plugging those cues, addressing them with big fat empathic responses. So it sounds as if you've been struggling. It sounds as though you've tried lots of strategies already. Seems like you're good at. Gosh, I hear what you're saying. And then R is reflective listening. I've heard you're motivated to address your diet. I can hear you are really frustrated with the fact that your mobility has really deteriorated. I'm hearing that you are really cross about the fact that we seem to have messed up your repeat prescription. And again, observational things. I notice, gosh, I can see you're tearing up with this. Or I noticed you really smiled when you started talking about the dog. So really noticing reflective listening, the difference between active listening and reflective listening, which I know we've talked about before. And if you're a bit stuck thinking about active versus reflective listening, it might be time to have a pause point and to have a look at that and have a discussion in your group about the difference between reflective and active listening. And then we move on to summarising. So actually, let's go over what we've talked about now, and then linking that summary. So coming back to the ICE, You mentioned that you wanted to talk about Pilates for your back pain. Should we talk about that more? You mentioned that you were wondering about having some CBT. Should we talk about that? And then a transitional summary. So actually about what's going on next and what other questions that they might have before they leave. So if you want to talk about reflective active listening, now might be a pause point. Otherwise, we are going to go on to something else. So this, I appreciate, is quite a busy slide, but I think it's actually really quite helpful in terms of thinking about explanations and how we explain things. So I think one of the key things here is about that headline. So that single sentence to set the scene. I think what you have here is a condition called COPD. Pause, stop, wait. You can't do any planning. So you can't say, I think you have a condition called COPD. So what we're going to do is, it doesn't work. You need to take them on that journey with you. You need to hold their hand, walk them through, take them through those stages. And again, don't say to me, well, don't worry, because actually you may be trying to be reassuring, but they might not have considered worrying. And now they're like, oh my goodness, oh my goodness, oh my goodness, oh my goodness. And then they're not going to be listening. So single sentence, set the scene, stop. And then a fuller explanation. And I think this is where I love Hellman. Remember Hellman? So what has happened? Why has it happened now? Why me? Why now? What happens if we do nothing? And hopefully at this point, you've got their ice, you've got their ideas, concerns, and expectations. So as you start explaining things, you were telling me that you're getting very breathless quite a lot of the time, and you're coughing up a lot of phlegm most days. And sometimes you find that you're quite wheezy, your chest's making funny noises. And we talked about the fact that you've had 5 or 6 chest infections over the last year or two, particularly in the winter. And each time you're feeling your chest isn't getting any better. And I know it was great that you did manage to stop smoking 5 years ago, which is fabulous. But of course, we know you smoked for 40 years, didn't you? So putting those things together, I wonder, like you do, you said you thought, did you have emphysema like your brother? And actually, I think you may well do. And that's something we sometimes call emphysema, sometimes call COPD. But I think what you were thinking about may well be what's going on here for you. And then again, a little pause. Actually, at the point where you start thinking, you know, is there going to be something really frightening, worrying? If you're breaking news of something more significant, you know, you're thinking about, actually, I'm worried that you've got hematuria, for instance. Obviously, we're not going to say hematuria to a patient because actually they need to think about you've got blood in your urine. And I do think that is something we should take very seriously. I want to say that can be a sign of cancer. You can come on to that in a bit. And there's a big difference between respecting that duty of candor and talking honestly to people and not lying to them, not colluding, not telling them untruths, and actually giving information in a way that they can understand and take in. So actually, if you're risking saying something like life-threatening or terminal, probably worth just holding that back and thinking, is there another way that I could phrase this? I'm not talking about using euphemisms that are so woolly and fluffy that they don't mean anything, but I do think it's worth just thinking about softening what you're saying, but making it still truthful. Chunk and check. Are they with you? Read them, look at them, look at them. And that's where actually a video consultation or a real life consultation is so much better, isn't it? Because you can read what's going on, you can look at their body language, you can see what is happening for them, and you can take it at the right pace. And that's, again, one of the things that's hugely difficult when you're consulting on the phone. So again, that may be worth having. You might want to screenshot that slide and come back to it when you're doing some of the exercises a little bit later on in terms of explanations as a model. If you're somebody that really likes models, that one might be really helpful. So going to move on and just show an example, because it's all very well to say how to do it, but sometimes it's actually better watching it in real life. And I'm hoping most of you have already discovered the Pennine BTS and particularly their YouTube site, which is fabulous. But I think this is a really, really good example. And I really think it's worth watching this, particularly the explanation. And we are thinking about explanation at the moment. So actually, if you want, feel free to stop the clip at the point where they move on into the management phase. Though I also think it's worth watching the management phase to think, actually, it goes downhill. It's not terrible, but it's not something you really, really want to model, because that management is actually really quite doctor-centered. but the explanation is fantastic, and the management is okay, and possibly quite a lot better than some of you are managing at the moment, but I wouldn't hold up the management as a really gold standard, but the explanation I think is really good. So now this is the point to pause this video and look at those links. The links, again, as I said, are in your handout, so they are there, so you can click through onto that link and watch this next video. And once you've done that, have a little think about it and talk about what you've seen. For maybe it's a 3 or 4 minute video, and then sort of 5 minutes discussing that as a group, and then on to the next thing. Brilliant, welcome back. Hopefully you are all still with me. So 30-minute task now, probably time for a quick stretch, loo break and what have you. So here we have a click to spin exercise for you all. So on this spinner, and again, the link is in your handout, what I want you to do is use this in your group and take turns. On this wheel, there are a whole load of different things to explain to a patient, and I want you to focus on explanation. You are not data gathering. This is not role play and imaginary conversation. This is pick up a single example. So it's short, snappy, quick explanations, and be sensible with your feedback to one another. Be kind, be specific, give people developmental points if there is development to do. Really important, just thinking about some of those rules of feedback, which I hope you all know well by now. We're really thinking about how you're doing this, but actually play with this, have fun with this, spin the wheel, have a turn. If you don't do it very well and somebody gives you some feedback, okay, then your turn. You show me how to do it, you show me how to do it, take chances, model, see how you're getting on with each other, and absolutely feel free to screenshot that URL if it's something that you want to practice. If you get really slick with explanations of all of those conditions, that's going to massively improve your consulting and save you loads of time in the RCA as well. So you've got about 30 minutes to do that. So time to pause this video for now and then go on and do that exercise. So welcome back. You've had your 30 minutes exercise there, and I hope you've had a little bit of a walk around and a cup of tea and what have you. We are moving on now to talk about shared decision making. And I want you for a moment just to stop and think about what shared decision making is and why it's important. I want you to pause the video now. And I want you, when you pause the video, just to think about what is shared decision making and why it is important. So maybe 2 or 3 minutes of that, and then I want you to watch this osmosis video about shared decision making, and again spend a couple of minutes talking about that and what you found at the end of that video. Brilliant, welcome back. So we now know what it is and why it's important and why it's useful, which is grand, but actually how are we going to do it? And I think there is a real problem here, because it's not just saying, well, we could do this, we could do this, we could do this, we could do this. What do you want to do? That's not really very helpful, is it? One of the analogies I use quite a lot is about, family dinner time with a toddler. You don't say, would you like some vegetables? You say, would you like broccoli or peas? Because both of those options are fine. I don't mind whether they eat broccoli or peas. I do mind if they don't eat any vegetables. So actually, let's give people a choice, provided those two options are balanced. But sometimes the decision that you're making will be more nuanced, and you might need to spin one of the options, might be better. So an example might be emergency contraception. We all know that a copper coil is the gold standard here. So anything else is inferior. But of course, a patient can have a choice. They may have a very good reason for not wanting to have a coil. But the coil needs to come as that first option. So the gold standard here, and the thing we would normally recommend, is to have a device fitted into your uterus, something called a copper coil. Have you heard about coils? Do you know about contraceptive coils? Okay, so one can be fitted, and we know that's got an incredibly high chance of preventing this episode of unprotected sex resulting in a pregnancy, and also can remain as your method of contraception for actually up to 10 years if you wanted it there, though clearly we can remove it sooner. there are other options. There are some pills. There are 2 different tablet forms that you can take, though actually looking at the medication you're on, actually one of those probably wouldn't be suitable. So there is a tablet option, and that's absolutely fine. And people often want to have what they would call the morning after pill. That's absolutely fine, but it's just worth being aware that the copper oil is a bit more effective. So, you see the difference there? I hope you see the difference. And again, it's looking at your patient's face, and it's ice, managing depression. If somebody comes in and says, I'm just not a talker, I really struggled to talk about this, I really was thinking maybe you could prescribe me some tablets, coming out with, well, we know the thing that's really effective for depression is CBT. That's cognitive behavioural therapy, a form of talking therapy. It's not going to work. It's not going to work. Doctor's hopeless. Don't like that, doctor. It's not going to work, is it? Where actually, coming back to, you mentioned earlier that you were thinking about some tablets and you really struggle with talking, and I hear that, and I think that's really relevant, because we know in managing depression it's often really important that you've got faith in the treatment working, not because of placebo effects, but just because we know actually if we are encouraging somebody to talk when they struggle to talk, or we're asking somebody to take tablets that they don't really want to take, or that they don't like, or that they're afraid of, that can have a really big impact on the relationship between the doctor and the patient, and the ability to get better, because the treatment isn't going to be as effective, especially if you're really not managing to get on with it. So again, I think that's, it's just important to think about those options. There are lots of options out there, but it's actually spinning them and weighting them and thinking about what's most important, not just vomit up a whole load of possibilities and then look at the patient and say, you choose. Because then you go, well, I don't know what to say, I don't know what to do. And you think, actually, I haven't done that very well. So have a look. Again, pause point, another Pennine VTS video. And again, think really carefully about the difference between the vomit it up method and that kind of more nuanced discussion with the spin on. Brilliant stuff. Welcome back. So sometimes we're thinking, what are the options? Are there options? And I just thought I'd just bring in this, which is Rapiro. And there is a handout again. On your handout, there is a link to a load more information about Rapiro if you want to think about Rapiro, which is just a mnemonic thinking about what can you do? What do we do? Because actually we don't investigate everybody. We don't always do a prescription, do we? But what do we do? So Rapiro just stands for reassure, advise, prescribe, investigate, refer, observe. So they are all possible management options, aren't they? And it's just worth sort of keeping those in your head in terms of, we could think about this, we could also think about this, and we can think about this. But again, just having those in your mind, in terms of where you're going to go and those management options. And yeah, have a look through that handout if you want to. We'll take that away to use later. But I think it's just quite a useful mnemonic to have in your head. Think, oh my goodness, what can I do for this person? What are the options? What do I do next? And I hope at this stage of ST3 you're quite well beyond that, but you might not be. So actually, sometimes if you get a bit stuck with something, what could we do next? So on to our second exercise. So this is much more about the shared management. So here we have an electronic deck of cards. So again, the link is in your handout. So taking it in turns, what I want you to do is to deal a card. They come up at random, and then you have 2, max 3 minutes to come up with a shared management plan. Again, we are not data gathering. We are hoping we are presenting some interpersonal skills and building some rapport in terms of how you do the explanation. But this is very much, again, management. What are the options? So there may be some clinical medicine that you get a little bit stuck with. So you might need to go away and read some clinical medicine, or you might need to phone a friend to get some clinical medicine. But it's just planning, working out, how are you going to do this? How are you going to share this management? How are you going to think about management options? How are you going to make sure you come up with a shared management plan? And I would suggest that you spend another half an hour or so on this part of the session as well. Brilliant. So you're still with me. You will be glad to know we've reached the end. So fantastic. Well done for getting to the end. Please can each group email the GPST office to confirm that you did get to the end, and confirm who was in the group, and maybe 3 or 4 learning points from the group, for some feedback. And again, if you want to add to that, whether you've enjoyed it or not, and whether you find working as a small group is useful, that would be hugely helpful for me. So that is the end for now. Thank you very much for your hard work, and I hope it's been a good afternoon, and I will see you all at the mock RCA on the 22nd. Bye for now.